Right, thanks everyone, and thanks to the previous speakers today. Great topics. I always say that motion management is more an art than a science, and I think that's where the beauty is. But here we're going to shift gears a little bit, and we're going to see how to use those images that we get during our IGRT procedures. So nothing to disclose. So we're going to identify some common IGRT techniques used for SRS SBRT, understand fusion and registration for these treatments, understand different options for deformable image registration, and the need for dose accumulation. So image-guided radiation therapy, as we all know, is the process of using different imaging technologies to locate a tumor target prior or during the radiotherapy treatment. Fortunately, the adoption of IGRT and all the vast and broad availability of different modalities has made older body frames and fiducial-based systems obsolete, or at least less needed. We use it to define and localize the tumor and normal structures before treatment, and to accurately and precisely deliver treatment. And this is particularly important, as we all know, in SRS SBRT, where our margins are really small, like 5 millimeters, 3 millimeters, 2 millimeters, 1 millimeter. It helps to give less tissue toxicity because we can reduce the margins because we know where the tumors are. And this is also important in hypofractionation because of the impact of geometric uncertainties. And then it's, as we all know, it's really making online adaptive radiotherapy possible. So some of the in-room imaging techniques, and this list is getting longer and longer by the day, computed tomography, X-ray radiographs, fluoroscopy, MV imaging, COM-beam CT, optical tracking, magnetic resonance, PET imaging, ultrasound. I think now we can add, Cherenkov imaging. We can add thermal imaging. So this gets longer and longer. So, and just as an example, X-ray radiographs. So we use this constantly to set up our patients because now most of the linear accelerators will have the capability. And the same with COM-beam CT, which is, for the most part, in most treatments, is the ground truth for setting up our patients. And this is how we usually see. So we have an image, the image of the day, prior to treatment, or sometimes we also acquire during treatments, and we have a reference image, which is normally our planning CT. And then we use this to properly position the patient for treatment. So very commonly used 2D imaging, KV radiographs. We use that mostly for bony anatomy matching and also fiducial matching. So something that has high intensity in the images. And then we use 3D imaging, for, like COM-beam CT, for example. And then we use also for bony matching. We can also use it for fiducial matching. But one of the advantages is the soft tissue contrast, better soft tissue contrast from the 2D radiographs. So for example, an image for spine SBRT, we would use here 2D KV imaging to properly, align the patient, make sure that there are no gross rotations or translations. We can contour some of the bones, like in the spine, some vertebrae, some ribs, to make setup easier to see. And then we would take a COM-beam CT and finalize our setup. The same for brain. We would also do KV, and then COM-beam CT to fine-tune our setup. For prostate, normally COM-beam CT is very widely used, prostate SBRT, and normally set up based on soft tissue on the prostate itself. Lung liver is the same. Usually we do a KV, so we can straighten up the patient and do then COM-beam CT to the tumor itself. So, as mentioned before, orthogonal images very commonly used for initial setup before fine-tuning with COM-beam CT, bony matching, fiducials, or targets with minimal organ motion or generous margins. So that would normally not apply for SRS SBRT. Combine CT, soft tissue target, possible rotations that we cannot see with 2D KV, although there are better algorithms now to translate 2D to 3D motion. And then anything near organs at risk and tight margins. But of course, we cannot forget about the more recent adoption of MR in the clinic, which of course gives us much better soft tissue contrast and allows us, or will allow us, to have much tighter margins. Also because it gives us real-time information, so we can continuously monitor that motion during the treatment. And then PET, which we know it gives us information about high uptake areas, and we still need to really learn about that and see how are we going to use it in the clinic. So some considerations, we can also use multimodality. So for example, and apologies, this slide was 2 slides, and when putting it here, I deleted the one without all the crosses. But when sometimes we use our planning CT in combination with other images, like MR, where we can better see some of the, for example, the target. And then we pass that information from the MR to the CT. But, oh, sorry. But between the CT and the MR, the patient might be in different positions. There might be, organ filling, respiration changes, and general anatomical changes. And there can be errors that will get propagated through the treatment planning and of course, throughout the treatment. So at our clinic, for example, for all our prostate SBRTs, we just do MR sim, so we don't do any CT, we just do an MR. And then we create a synthetic CT. So we put the contours on the MR, and then create a synthetic CT, which will give us the Hounsfield unit number that we need for treatment planning. And then we can plan on that, and we can create with that synthetic CT, we can create even DRRs for setting up the patient later. So we've done that, of course, put coils, different coils and specific coils for that, for the MR portion, MR sim. And here you can see the contrast in the MR images that we get, and at the end, in the lower part here is where our MR CAD prostate synthetic CT is, and that's the one that we use for treatment planning. And then this is an example of DRRs that we can get from the MR CAD. So we've been talking about this, and in the previous talks, they've talked about registration and fusion. So what is image registration? It's transforming 2 different sets of data into one coordinate system. So we can align the images, and we can superimpose the images. And then we use interchangeably the terms registration and fusion, but there is a distinction between those 2. Registration refers to the geometric correspondence between the voxels in the 2 different images, while fusion really means using the information from one image, putting it in the other image, and then transferring that information into your other image. And this really relies on the rigid and deformable image registration. So this is a typical SBRT, IGRT workflow. You do a SIM, you get information from other images, could be MR, could be PET. You do fusion of those images, and then do your treatment planning. Patient comes for treatment, you do a setup, you acquire the image of the day, and do registration with your reference image, which is usually your planning CT. You assess and see if you have to reposition the patient. In that case, you might, depending on your policy at your institution, you might reacquire a new image or not, and then eventually treat. So what things besides patient setup do we use registration and fusion for? We use it for motion management, like you've seen today. We use it for contouring. We use it, for example, and that's a very, it's that increase in trend, retreats. Patients come for treatment. They were treated a few months ago, a few years ago, and we really need to see where the patient was treated, see if there's any overlap with the treatment that we are giving today. Of course, adaptive radiotherapy, and then dose accumulation, which eventually might be needed for outcome studies and treatment response. So to see if a registration is good or not, we need to use some metrics. But there are basically two classes of metrics that are commonly used. One is voxel intensity based. So for example, the sum of square difference or mean square difference, correlation coefficient, and mutual information. But we also have feature-based, point-based, and contour-based. So let's go through a couple of those. Cross-correlation, which we normally use for single modalities, so CT to CT, MR to MR, really assumes that there is a relationship between the intensities of the voxels in both images. Mutual information instead assumes that there is some relationship between the probabilities or statistics of intensities in one image and the other image. So it's not a direct relationship between intensities, and that's why this can be used for multimodality, and is the one that is usually used for MR to CT, for example. You can have point-based registration, so that means you have fiducials or markers or landmarks in both images, and then you really drive your registration to make the position of these markers match. But you can also do contour-based deformable image registration, which really assumes that this contour in this image perfectly corresponds to this contour in this other image. So you use that correspondence or that relationship to drive your DIR. Now, point-based and contour-based can be used in combination with other methods, and then it really can help the other method to provide a better deformable registration. And then we have multiple algorithms on how to do deformable image registration. So we have geometric algorithms, so rigid, affine, freeform, splines, and we'll see a couple of those too. But we also have physical models, so viscoelastic or optical flow, finite element methods. So rigid registration really means translations and rotations. There is no more you can do with a rigid registration. However, if you add shear or scaling, then you call that an affine transformation. Deformable image registration is really used when none of those really work, and that really corresponds or fits many of the applications that we have in radiotherapy. Changes in anatomy, weight loss, tumor response or tumor growth, for example, different position of the patient from one image to the other one, different breathing. So for that, we use other methods like B-spline deformable image registration. So B-spline really, you have the B-splines, which are these little functions. They're local functions, so they only affect, each of these only affects a few voxels. And then you assume that the motion in each voxel in each direction is a combination of these little functions. And then the deformation vector field, the global deformation field, is really a combination at each voxel of these little B-splines. And your optimization code or algorithm, what it will do is to find the coefficients for the linear combination for each voxel. And then we have biomechanical driven deformable image registration. So this is really, you have an image. This is, in theory, the most realistic one that we can use. We have volumetric information from a patient. Then we can say, okay, let's contour the liver. So now we define the liver as an organ. So this is organ-based, basically. You do a mesh of the liver, so you split that in, it can be tetrahedrons depending on what mesh you use, but little volumes, and you assign them a biomechanical property, so elasticity, for example. How is that deforming when you apply compressions or when you expand, when it expands? And then you put that into a finite element model, so algorithm, and you give it some constraints, motion constraints, and you optimize for that and see how it deforms to take you from one image to the second image. Now, these models used to be very computationally expensive. I think these things are improving with all the advances in computation. But it really needs biomechanical properties for everything. And important is you have to contour each organ independently. It's intensity-based. They're not probably, it doesn't give you any information about biomechanical properties, but you just give one image and get another image. Here you have to define each organ or each part of each little structure and give it some mechanical properties. And then, of course, more recently, the use of deep learning-based deformable image registration. This, in contrast with the other ones, it's almost like a black box for us. We don't fully understand what's happening, but there's been great progress on deep learning-based deformable image registration. So you train your model with a deep network, and then once you train the model, test it, evaluate, then you give the two images, and it will just give you the deformation vector field. So we can use this for segmentation. When we have one image, for example, an MR or a node image, and then you can really see the tumor here or some organ at risk, and you can deform that to your current image, then you can really use the contours from your first image in your planning CT or whatever image you need to use them from. And this is very commonly used in atlas-based auto-segmentation. If any of you has any algorithm that uses atlas-based auto-segmentation, it's what it's doing. There are different ways to do it. So you can just have you have one atlas or database that has just one patient, and then you deform that one patient who has everything contoured. You deform that to your new image, to your patient image, and then you transfer those contours. You can have multiple atlas, multi-atlas, so you have multiple patients in your database or fake patients or prior patients. And then you deform those to your new patient, and you will get different things, of course, because deformable image registration, as we have seen these days, is not completely accurate. And then you arrive to a contour consensus that you can use. This third one is very common. You have a database with multiple patients there or multiple data, and you pick your best match from that, and then you deform that one picked patient to your new image and transfer those contours there. And then the last one is a combination of the previous ones. But also, once we mention this, we also have to mention deep learning organ at risk auto-segmentation, which again, there is a lot of work put into this, and it's really helping out in a great way the auto-segmentation, and it's in many cases giving us better results than atlas-based auto-segmentation. And you can also use it not just for organs at risk, but there is a lot of, organs at risk, as you can imagine, and if you go to, AAPM, Astro, you go through the vendor booths, and there are many companies who are working or have already developed these things, and they sell that product with these things. Of course, there's always improvements to be made, and they don't have all the organs, but it's becoming very, very widely available. Tumor segmentation, not so much yet, so there is a lot of work to do still in tumor auto-segmentation. So this is what a typical image-guided adaptive radiotherapy workflow looks like. So very similar to before. On this side, we do the fusion, you do the setup, you acquire the image of the day, you do a registration with your reference image, and then you assess and say, hi, this is not looking great, so I think we really need to replan. So you do fusion again with your prior images, and different systems will have different capabilities. But really, you can do fusion with your prior images, your prior planning CT, or any other image that you have, and then you do replanning, and then continue and eventually treat the patient. So adaptive radiotherapy, if we look that up in PubMed, we can see the almost exponential increase in the use of adaptive radiotherapy in the literature now. So for the summer school organizers, maybe we have to define, a threshold over which we organize a summer school on adaptive radiotherapy, maybe. Types of adaptive radiotherapy, we have offline adaptive, online, and real-time. The difference is offline, it's not new. Many institutions do that, for example, for head and neck. It takes hours and days. It's adaptation to slow changes. It's infrequent, maybe once or twice per treatment course. Less resource intensive. It's resource intensive, but it's more flexible. And then can use diagnostic images. Online takes minutes. You adapt to daily changes. You do that more frequently, maybe daily, maybe weekly. It's resource intensive. You need everyone ready for that at that moment. And because we need it now, it really requires a higher degree of automation, or it will really benefit from a higher degree of automation, and uses the onboard images for adaptation. And then real-time adaptive, so this is more related to motion management. It takes seconds and adapts to motion. Why adaptive? I think it's, there's been some, we're doing adaptive because we know it works. But online adaptive, I think we are starting to get publications about that. I'm just going to show here one that was used on oligometastasis of primary liver or non-liver abdominal malignancies. This was done with an MR-guided adaptive radiotherapy, 50 grays in 5 fractions, and they did daily online adaptation when needed. So what they observed is that in 21 out of 97 fractions, they did adaptation. And the main reason for that was really to protect the organs at risk, or to be able to escalate the dose for better coverage of the PTV. This is the images that they were getting. So again, great soft tissue contrast is something, particularly GI is a difficult one to see in common CT. And then they could improve the DVHs, better organ at risk doses, and better PTV coverage. But what they saw is that sometimes it's not just escalating the dose. Sometimes you need to de-escalate if you really need to protect your organs at risk. And again, it's something that you couldn't do without adaptation. So these are some of the available systems that we have for IGRT adaptive radiotherapy, X-ray LINAC, MR LINAC, and PET LINAC. And I think we are really fortunate that we will be able to see that all of these tomorrow during our visit to UT Southwestern. So some of the difference in images that you will see, for example, MR LINAC, here you have multiple images from different fractions. Again, great soft tissue contrast, and always better plans when adapting. KV-based, it might depend on whether COMIM CT is good enough for your application, but it's more widely available. So eventually, everyone has a KV-based LINAC. So hopefully, we will be able to really put workflows in all these LINACs that we have to do adaptation. But we will really benefit from improvements in COMIM CT. So I think that is crucial for wide implementation of this. And then PET-based, it's there. The LINAC portion is there. The PET portion is coming soon. And I think with this, it's biologically guided radiotherapy. A big area to explore, and I think we will learn a lot on this new line of research and clinic. So with all this, now let's talk a little bit about dose accumulation. So dose accumulation is the sum of the delivered dose with the changes in anatomy. So we needed to assess the delivered dose versus what we planned for. We can use it for better accuracy in outcomes studies to adapt future doses based on what has been delivered before. So if you know what has been delivered before, you can create maybe a better plan for the future. And then could be used in the adaptive radiotherapy context, also in the retreatment context. So the first step for dose accumulation is you calculate the deformation vector field that we did, with deformable image registration, and then you warp the doses from one image to the next one. Typical workflow, you have your planning CT, and then you have your images of the day. You deform those to a common reference and deliver those doses that you have calculated on them to one common image. And it could be one image. It's really based on, at this point, on the preference of what image suits you best to have the cumulative dose. Some considerations is once we have all these capabilities and it's accurate, in what cases would you do physical dose versus biological dose, and how do you take time lapse between, for example, treatments into consideration? So let's say a patient was treated 5 years ago versus 2 months ago. How do we take that into account? And then another consideration is the mass melting. So all the DIR algorithms that we've seen today are based on the one-to-one correspondence of voxels in the deformable image registration. So it means there is always one voxel in one image that corresponds to another voxel in the other image. When the tumor resolves, for example, we lose that one-on-one correspondence. So we need to come up or study this a little bit more and see how are we going to deal with this. For outcome studies, I think many outcome studies are based on the planned dose and the toxicities that were observed in the patients. But dose accumulation, in this case, for example, this group presented that the total accumulated delivered bladder dose was superior to baseline dosimetry in predicting acute treatment-related increase in urinary symptoms. So something really to take into account once we have good methods for dose accumulation. And then the last thing to mention is we cannot forget about errors in the deformable image registration. So just to show in this paper, they did evaluate the error in the deformable image registration by several commercially available methods. And as you can see in the graph, sometimes the errors are small, but not always. So every time you do DIR in your clinic, you really, really, really need to evaluate and make sure that it makes sense. It's really patient-dependent, anatomy-dependent, algorithm-dependent. So there is no one number for everyone. So it really needs to be evaluated in an individual basis. Errors will propagate through counterpropagation, through dose accumulation, into adaptive radiotherapy, and into outcomes model. So we really need to be conscious about that. And we need more research to quantify and understand these uncertainties and really define how to use them and evaluate their impact. So in summary, really IGRT has many flavors and imaging modalities. Registration and fusion continue to evolve as we improve imaging and add more modalities. DIR plays a crucial role in many of these tasks: auto-segmentation, adaptive radiotherapy, and dose accumulation. But we really need to be cautious about accepting the DIR that our algorithm is giving us. because all the errors, as we've seen, propagate into other tasks. Now, we've made great progress in all this, as you can all, I'm sure everyone agrees, but we really, it doesn't end here. We have a lot more to work on. I'd like to thank my whole group, but in particular, this group of people, they keep these conversations about the topics that we discussed today alive. And then, of course, the AAPM and summer school organizers and program directors, UT Southwestern just for hosting us tomorrow and really showing us all these great machines that they have. And the audience, because I think we've had great conversations these days that many of us will take, I think we're learning a lot and taking something back to our institutions. So thank you.
So, we have time for questions for Dr. Savino.
Yeah, thank you. Very nice illustration of the very comprehensive on the registration fusion. I have a question. I especially appreciate you outlined the 3-step registration, intensity-based, and then point-based, and then contour-based. And I find a great application in our prostate SBRT cases, where we increasingly escalating dose from PTV to boost dose to prostate, and then intraprostatic lesion inside prostate. So in order to do that, we need a very detailed fusion procedure, like CT to MR first intensity-based, and then prostate between MR to CT, we use fiducial-based, point-based. And then finally, if we want to introduce the lesion, we need to use multi-parameter MR. And there's no fiducial in those functional MRs. So we use the contour-based. Yep. Contour prostate and match prostate profile and the muscle features. So all these require some probably non-standard tools. So my question is, at Sloan Kettering, what kind of tool do you use for these very special, subtle treatment?
Yeah, it is tricky. So for prostate in particular, like I said, we just now use MR SIM, so we forgo the CT. We don't have a CT, which makes part of the problem easier. And then we do, for the formable image registration, we use a commercially available system. We use MIM.
Okay.
Yeah. But we always look at it closely also. We are very careful. We don't use the formable image registration for everything. But more than anything, for adaptive radiotherapy, for example, we really do auto-segmentation, which is not based on the formable image registration. So we also forgo, remove the uncertainty of the deformable image registration because we do auto-segmentation, which is not based on deformable image registration.
Very short follow-up question.
Yep.
So these processes very time-consuming. So we can understand Dr. Park mentioned it sometimes took him an hour to fuse a case. In case like this, it will take probably more than an hour. And how, at Sloan Kettering, the physics resources is assigned to such kind of physics support to SBRT?
Yeah, so in particular for prostate, we have a great auto-segmentation model that we use for all our prostate patients. So we do the MR-SIM, and then it goes into, it's homegrown software. It goes through that and has all the contours there already. That has saved us a lot of time. So I think the future is auto-segmentation. But again, we all need to review those contours, right? For everything else, it's really manual fusion, like they would do anywhere else. So it's time-consuming. The dosimetries play a big role in that. So they're usually the ones who do the fusion, and then we review the fusion. And I think that's very common in other institutions too.
Does sometimes radiologists involved in peer review in some of this very subtle treatment?
Yeah.
Okay, thank you.
Hi, Tim Craig, Princess Margaret Hospital. Thank you for a nice presentation. So my question's a little bit similar, that we're currently trying to do more deformable image registration, more dose accumulation, and we're trying to be a little bit thoughtful about what the appropriate quality control for that is. So I was wondering if you might share with us sort of what the physics role in the quality control is for that at your center and how you develop those processes.
Yeah, so it's, we have a big effort internally at MSK on dose accumulation, which is based on deformable image registration. To be honest, we are very, very particular about knowing that it's not accurate, and we are very careful about that. So we don't have a wide implementation of dose accumulation yet. We are doing a lot of work on trying to understand the uncertainties from deformable image registration that will bring the uncertainties to dose accumulation. So for QA, something that you clearly need to see is to look at both images and see if the match makes sense. So I think someone mentioned earlier today, I think it was Dr. Park, sometimes when you deform and there are bones, it will deform your bones. That doesn't make any sense, right? So try to ignore all that. But really not much more than that. There are some metrics. Algorithms will, bring like the Jacobian. There are some metrics that we look at when we do deformable image registration. But again, I think it's an area that needs, like I said at the end, it really needs more work. Try to understand the uncertainty. We don't have a ground truth, right? That's the problem with deformable image registration. And I don't think there is a good method. There is TG132 that reports on, on all these and QA methods to do. There are publicly available data sets where you have, they're fiducial based. You can run your model on those and see how well your model does. But when it comes to your specific patient, you have to have done that prior QA, right, like IGRT QA, but then, for example, translated to the deformable image registration. But you always need to look at the deformable image registration that you're getting, because it's really very individualized. The uncertainty is not global. I don't know if that helps, but there's much more work to do in that area, unfortunately.
Thank you.
Yeah.
Hi, Anand Krishnamurthy. I'm with Kaiser Permanente in South San Francisco. Can you tell us a little bit more about the synthetic CT? Is it a commercial product or is it a homegrown? And have you thought about it for other body sites?
Yep. So in our case, it's commercial. Sometimes it's through a research license or like a research agreement with the vendor. But we really work with them on developing that. That predates me. It's not me. It's a work group. We are working, but I know some people have developed their own. So sometimes, we've brought that up. Is like, should we develop? I think vendors. Some vendors are working on it. I think it's not widely used because one of the problems is not everyone has an MRSIM, right? So I think that limits, the prioritization sometimes of the development that the commercial systems will have. That being said, yes, we are looking at other sites like head and neck, brain. I've shown MRCAD that presents bulk density, so you see it doesn't really look like a CT. It's really like 5 different areas, shades of gray. But we have now a better model, and when I say we, is also with the vendor, right? It's not just me. And then we are hoping once we implement that better model, we can translate that into GYN also, and anything pelvis. So those are the sites that we are looking into right now.
Thank you.
Yeah.
Hi there, Xiaojin from Marion. I'm curious about for the geometric distortion assessment for fusion, what's the criteria do you recommend when we're assessing like target displacement? Thank you.
You mean also the uncertainty when you deform one image to the other one?
Yes.
Yes. So there is only so much we can do, right, with tools that are given to us. Some systems have some metrics that, for example, calculate the Jacobian of your deformation vector field. So if you have this voxel, if you have two adjacent voxels and one goes in one direction and the other one goes in the other direction, that's a no. It's not possible, right? Because the motion has to be continuous. So that's just one metric that you can look at in your algorithm. And then really visual, if you have landmarks, again, bones should not deform. Anything that around you or around the area that you are looking at that can help you visualize that you are really getting a good match. So anything, edges in your images, for example, that can help you. But like I said, it's a tricky one. There's not a ground truth, and there needs to be more work on that. What people have observed is that, and some software, some algorithms allow you to do that. Sometimes you can fix some points because you know that this point corresponds to this point, right? Like a point base. And you say, okay, I want these 2 points to match and this third point to match to this other point. And then that helps guide your deformable image registration. And the same with contours. If you have contours in two images that that those are the contours that you want, and they're easy to contour, let's say, or then you can use, the software can use that to guide your deformation field. Yeah.
Okay. One more question, please.
Hi, thank you for the talk. I'm Sagrika from Ohio State. Have you looked at any inter-user variation in generating DIRs?
In generating DIRs, no. Great question. No. I thought you were going to say contours, but no.
Okay. No, I know we're starting to use MIM as well, and I know there's defined workflows, but we're just thinking if, based on the user, if there's differences in the quality of DIR generated.
Yeah, it's interesting. I think if it's completely automated, hopefully it's not. There's not variability, but if there is anything done manually at the step, like let's say the initial rigid registration, for example, or locking points, right? Then yes, there will be. But good question. I haven't heard of anyone looking at that. I don't know if anyone has.
Thank you.
So I'd like to thank again both speakers and close the session.